Hello, my name is Ian McCall. This is a talk on sweet syndrome, the clinical and histopathological variants. Dermatologists really like sweet syndrome. It's one of those conditions that they sometimes can diagnose over the phone, just with the history of a patient, say with some form of inflammatory bowel disease developing a nodular eruption that hasn't responded to antibiotics. The first set of cases were published by Dr. Robert Douglas Sweet in 1964 in the BJD. And he described 8 women he had seen with cases of what he called acute febrile neutrophilic dermatosis in a 15-year period from 1949 to 1964. Now, he initially called it the gum button disease. These were the names of the first 2 patients, the surnames of the first 2 patients that he had seen, but I think I'm glad that it was eventually named after Dr. Sweet. These are the typical lesions that you see. This is the typical histology. The lesions themselves are usually violaceous to purple nodules, sometimes plaques. And the histology has the components of a neutrophilic infiltrate that's primarily in the upper dermis, but can in fact go a lot deeper. There's usually some form of subepidermal edema. It can be a little or it can be a lot. And there may be a slight degree of epidermal hyperplasia. As far as the types of sweets go, it's classified into 3 types. There's a classical type, which is primarily post-infective after pregnancy or during pregnancy, or with ischemic bowel disease, with inflammatory bowel disease. Then there's the malignancy-associated type, particularly with myeloid problems, but also with other solid tumors, and the drug-induced type, particularly with granulocyte colony stimulating factor used to treat some of the myeloid disorders, but also with a variety of other drugs. To diagnose classical sweets, you have to have the 2 major criteria, this abrupt onset of these painful erythematous plaques or nodules, with histological evidence of this neutrophilic infiltrate without evidence of leukocytoclastic vasculitis. And then there's the 4 minor criteria with fever, which they virtually all have, some underlying cause, an excellent response to treatment with systemic steroids, and some abnormal lab values, particularly an increase in the number of leukocytes. Now, what causes so many neutrophils, white cells, to come into the inflammatory infiltrates in sweets? The honest answer is we don't know, but immune complexes, particularly in the infectious disease-induced types, seem to induce excess cytokines. You can get cytokine dysregulation, and there is a genetic susceptibility to this condition as well, which also indirectly leads to excess cytokines. The typical clinical presentation we've described, the uncommon ones are bullous or vesicular sweets. You can get a subcutaneous sweets, a plaque-type sweets. There's the variant called bullous neutrophilic dermatosis of the dorsal hands, and rarely you can get a necrotizing fasciitis-like picture. There's the pustular variant that's particularly seen in ulcerative colitis, and there's the erythema nodosum and lobular paniculitis variants. Let's get back to the classical sweets. These are the lesions, particularly seen around the head and neck area, but also around the joints, elbows and knee joints. Violaceous papules or nodules. Often they may have small pustules studied within them. And it's just a reflection of the degree of neutrophilic infiltrate. This was the histology of that particular patient. This was a slide that was given to me by Mark Ash about 13, 14 years ago when I first saw that case. And it shows the principal features. A little bit of epidermal hyperplasia, it's a bit stretched there, the subepidermal edema, the inflammatory infiltrate, particularly in the upper dermis. But look at the involvement down here of the fat layer and some adnexal structures as well. All the other images in here are all my own. This was the case I showed you. If you go in closer, you see the nature of the inflammatory infiltrate here. You can see it's extending down around some sebaceous glands. You go a little bit deeper still, you get up close and you see that the infiltrate, there's a lot of the neutrophils, but a lot of eosinophils here as well. And I've seen that not uncommonly when I've looked at a lot of the lesions of sweets histologically. Generally, the neutrophils don't invade the overlying epidermis, but there are variants that will give a vesicular type of sweets as well. There's usually involvement around the blood vessels with some thickening of the lining of the blood vessels. There's sometimes involvement of some adnexal structures as well. And occasionally, you'll get a little bit of fibrin. This was Mark Ashey's picture from this particular patient 13 years ago, and he felt there was a bit of fibrin deposited in this vessel wall, but you don't normally see that. What about sweet lesion morphology? I think the first thing is some patients will show multiple morphologies in the one attack. In other words, they can get multiple clinical lesions. Let me show you this case. This was a lady who initially presented with these lesions on her forearm, and it has a pseudovesicular look. I mean, if I was looking at that, I'd wonder about herpes zoster, herpes simplex, ORF. But this lady also had a lesion that was inflamed and with a central pustule like this. She also had these small plaque-like lesions on her anterior chest wall. And she had these patch-like lesions on her forehead. And as well as that, she had a little lesion in her conjunctiva and another one on her lower lip. This one had initially been pustular, and then it became eroded, and you might have thought it was an aphthous ulcer-like lesion. So you can get varying morphologies. What about the patient who has similar-looking lesions, but they're at different stages of evolution? The important thing here is that the path changes with the age of the lesion. The neutrophilic infiltrate is less in older lesions, and it may in fact even become more lymphocytic. Let's look at this particular case. This lady had this lesion on her thigh, this one on the side of her knee. This is where we've done the biopsy. You can see it's a lot thinner. This one on the anterior knee, again, a lot thinner. And then this one on the other side of her thigh, more active, raised. And if you look at the histology of that more acute lesion on her thigh, this is the picture you see. Here's your infiltrate primarily in the upper dermis. There's perhaps a suggestion of a little bit of edema here, but nothing much. When you're looking at that infiltrate, you see some of it's perivascular, some of it's interstitial. And when you look in closely, you can see that it's certainly a neutrophilic infiltrate with some leukocytoclasis there. As you get up under the epidermis, you can see the edema here. There's perhaps a little bit of spongiosis there, not much, a little bit of separation of the keratinocytes. And if you look at the vessels, there's a little bit of endothelial swelling here, a little bit here as well, a little bit here as well. No real fibrinoid necrosis in this lesion. You can see some extravasated red cells up here, another one here. But then if you look at the histopathology of an older Sweets lesion in this patient, this lesion here that we had in the knee, you look in close, really not much in the way of edema here at all. The infiltrate, when you're going to see it, is going to be perivascular. And it's not terribly neutrophilic. There are some there, but most of that's in fact lymphocytic. So if you were to get a biopsy of a late lesion like that, you might have real problems trying to diagnose that as a late lesion of Sweets. But it goes back to Ackerman's thesis on the evolution of the lives of lesions. Depends when you biopsy them. Let's look at some other of the uncommon clinical presentations of Sweets. What about the bullous neutrophilic dermatosis of the dorsal hands? This has a similar histology to Sweets. It's usually an upper dermal infiltrate, usually marked subepidermal edema. It's often mistaken for an infective process. Same rapid response to oral steroids and a strong association with blood disorders. This was first described by David Whedon in the late 1990s. And this is a man who has that condition. You can see how infective, in fact, it looks. You can see there's a lot of subepidermal edema here. This is virtually being lifted off. And if you look at the histology of this case, it was a bit fragmented when it was excised. There's your epidermis, and there's this big collection underneath the stratum corneum of white cells. And if you go in closer, you can see the inflammatory infiltrate in the dermis here, but you've got all this inflammation underneath the stratum corneum. And you can see it's made up of lots and lots of neutrophils. They look quite funny in that particular view. Surrounding at the edge of that, there's a little bit of spongiosis here as well. You can see the infiltrate here in the dermis. This was that man after a period of about 10 days of high-dose oral steroids. The lesions had settled down, the inflammation had settled, but you can see the scabbing there from the damage that he had. The other variant of Sweets we might want to look at is the malignancy-associated Sweets syndrome. Now, it's usually seen in patients with an underlying acute myelogenous leukemia, or at least some myeloid disorder. It can be seen with other solid tissue tumors. They're fairly florid clinical signs. It's more likely eye and mouth lesions, and often bullous in the dorsal hands. This was a lady I had in Hobart many years ago, and this was how she presented. She didn't have a leukemic process at that stage, but 6 months down the track, she did develop a myeloid leukemia. This is another example from the literature of the type of lesion you can get in the malignancy-associated type. You can see it's virtually a pyoderma gangrenosum type lesion here. This is another lady we had with myelofibrosis who started to develop these lesions and subsequently evolved into chronic myeloid leukemia. And you can see how florid they are, presence around the eyes, presence around the mouth, on the lips themselves. And on the back of her hand, she had what we've come to expect, the blistering bullous lesions. What other uncommon clinical presentations can we have? Well, there's the pustular variant that we see with ulcerative colitis. Usually you get the combination of Sweets lesions and pyoderma gangrenosum in those patients. Prominent pustules, and often the pyoderma gangrenosum lesions are quite large. Here was one lady with underlying ulcerative colitis, not well controlled, who presented with these lesions on her face. You can see the marked pustulation associated with these individual pustules here as well. If you look at her back, these were the pustular lesions she had there. This was the anterior chest. These were lesions she had on her lip. You can see how the pustules have ruptured to give sort of aphthous-like lesions. And this was her facial one after a week or so of 2 weeks actually of oral steroids. It did leave a little bit of scarring there. She had this large lesion of pyoderma gangrenosum on her ankle at the same time as she had these other lesions. That's the more typical picture of pyoderma gangrenosum. This was another lady who actually had Crohn's who presented with this, and after 2 to 3 weeks of oral steroids, it had healed up to that. If we're looking at the path features of Sweets, it really depends on these various things. It depends on the lesion biopsy and the state of the illness. That's the most important thing. We've talked about the neutrophilic infiltrate without vasculitis. We've talked about the dermopapillary edema, the leukocytoclasia with endothelial swelling but no fibrinoid, and rarely a septal or lobular paniculitis. You can get epidermal hyperplasia. You can get a neutrophilic infiltrate giving subcorneal pustules, and these are the features too. Let's look at the vascular changes. Just a little bit more detail. We've said usually only endothelial swelling, extravasation of neutrophils surrounding leukocytoclasis, no fibrin deposition in the vessel wall, and if fibrin is seen, then it's usually collateral damage. It's usually the result of the toxic products released. This was a picture we showed before with the vessel here, a little bit of swelling of the endothelium here, some leukocytes surrounding this, and this was the case that did have a little bit of fibrinoid necrosis that I showed right at the beginning. What about lesions that mainly show a neutrophilic infiltrate giving subcorneal pustules? Well, there was this one here, which if you looked at it, really was a pustule that was from a dense infiltrate in the dermis itself that was actually rupturing through the epidermis. And you can see the extravasation of the neutrophils there. Around the edges was this dense edema, marked edema. But if you looked at the edges of that, you had these lesions up here. If you look carefully at those, there are little collections of neutrophils within the epidermis itself. You can see the extent of the neutrophilic infiltrate here. Here's another one. And if you look at it, you can see again a pustule that's sort of pressing into the epidermis here. Very, very thin supracorneal layer. And rarely, as I say, intraepidermal vesiculation. If they're going to present with intraepidermal vesiculation, they're often going to have lesions that look a little bit like this, pyoderma gangrenosum-like. And this was the pathology of that particular case here. Dense infiltrate. How much of this damage was due to cells infiltrating in there and damaging the epidermis? If you have a look, you can see the extent of the intraepidermal damage here. You can also get epidermal hyperplasia in sweets. And this case was particularly interesting because it was the one with the phone call where they said, can you come over and have a look at this patient who is in with Crohn's disease. He developed skin cancer on the back of his hand. He had it cut out, but it's recurring around the edge of the graft, and that's only in, it's less than 10 days since he's had it done. And of course, when you went over, this was part of the graft here, and this was the new lesion. When you did a biopsy of this, you can see there's a degree of epidermal hyperplasia here, but you can see the marked inflammatory infiltrate. The initial specimen, when the plastic surgeon sent it away, was mainly epidermal, and it was a bit friable, and the pathologist only got a top part like that and reported it as a well-differentiated SCC with inflammation. But if you actually have a look at it, you can see the marked neutrophilic infiltrate and the red cell extravasation and the classic features of Sweets syndrome. And lastly, there's a situation of plaque Sweets or erysipelas. What's the difference? In erysipelas, usually the neutrophilic infiltrate is less prominent and there's less leukocytoclasis. So there was this lady who presents. And the question is this erysipelas or is it Sweets? You can see the edema that she had here, but you get edema in erysipelas, but this was her histology. Again, picture very reminiscent to some others that we've seen with Sweets, with this marked subepidermal edema, marked infiltrate. And if you look down into the infiltrate, you can see the combination of leukocytoclasis and a little bit more lymphocytes in this one. A lot of leukocytoclasis there. Again, if you look at this area here, there appear to be a reasonable number of eosinophils in this infiltrate too. I did treat her with both dicloxacillin and with prednisolone, and this was the result after about 10 days. The edema is very, very much less. There are a few other little uncommon presentations of Sweets. This is pediatric Sweets. We don't usually see this. This is the erythema nodosum variant of Sweets. And this is plaque Sweets on the, another example of plaque Sweets in the forehead. And this was, a very vesicular variant of Sweets as well. So there are all these other clinical variants that I haven't been able to show you the histology of today. I just want to end up with reminding you about the systemic manifestations of Sweets syndrome. This isn't just a condition that affects the skin with associated bowel problems, some fever and leukocytosis. A lot of them get arthralgias, arthritis, myalgias, and some ocular involvement. And there's these uncommon things: neutrophilic alveolitis, multifocal sterile osteomyelitis, renal involvement. And then these rare ones of hepatitis, acute myositis, aseptic meningitis, pancreatitis, and GI involvement. So I think we've got to think of Sweets in terms of the systemic disease that it actually is. I haven't gone into aspects of treatment. Essentially, it's all about steroids, but drugs such as dapsone and colchicine can also be used. Thank you very much.